coming over here to the very important portion, obesity. It has been asked as a very, very important exam question, and it is increasingly being asked over, last 2-3 years. So let us understand obesity and let us discuss in detail. It is a little bit difficult topic in Robbins, but I have tried my best to simplify it. And at the end of the lecture, I'm sure that everyone will be able to ace this particular session. So obesity is basically defined as an excessive adiposity. And there are certain risk factors associated with obesity. As in, obesity increases the risk of diabetes mellitus. It increases the risk of hypertension, dyslipidemia, cancer, and also increases the risk of cardiovascular disease. Now, the best method to assess obesity is your body mass index. So you must have read about this in PSM also. There are different stuffs. There is vernier calipers, which is, but out of them, the one of the best is the body mass index. And there is a classical, classification in association with the BMI. So the normal BMI is anywhere between 18.5 to 25. Overweight is around 25 to 30, and obese is more than 30. And from where I can, I can recall, just correct me, around 30 to 35, they say class 1 obese. Okay, around 35 to 40, they say class 2 obese. And more than 40, I guess they say it is class 3 obese. Okay, this I think is given in your preventive and social medicine. So kindly recheck once. Okay, obesity over there, kindly recheck once. Okay. Now remember the central or the visceral fat. What is the central fat? That in our belly, whatever fat deposition is there in our belly, or which is present in the viscera, okay, in the viscera, that is in the internal organs, whatever fat has been deposited, okay, that is basically exemplified by truncal or abdominal cavity fat. Now, this fat is far more dangerous than whole body fat. So if you see a person that just has excessive amount of abdominal fat, this poses a much higher risk of development of other disease. Okay, and now in developing country like India also, the risk factor for developing obesity includes intake of refined sugar. So what is refined sugar? You are having tea with a lot of sugar, that is a refined sugar. You are having Coca-Cola, you are having any soft drink, okay, that you are having, that is a refined sugar. That is any kind of sweetened beverages, even the vegetable oil that you are cooking the food, that is also one source. Okay. Now, we have to understand that our hypothalamus, it is a central regulator of appetite and satiety. Okay, our hypothalamus is the central regulator of satiety, and so it plays a very important role in obesity. Let us try and understand. So first of all, what is the pathogenesis of obesity? Let us first try and understand. So we have to understand one important thing over here, that is the hypothalamus is the central processing unit. Okay, and it has two kinds of circuit. One is the catabolic circuit. Catabolic circuit means that is going to break down, and one is your anabolic circuit, that is going to build. Okay, so we have to understand that in our body there are lots of different types of signals that we get. So we have two systems in place. One is your afferent system, one is your efferent system. Okay, so one is your afferent system, from where the sensations are going to come, whether I should have food or whether I should not have food. Both of them can come. Over here, first just try to understand the basic. So the afferent system is one that is going to sense the signals, and accordingly it is going to decide whether a person will have or will not have. So who are these different areas of our body that is going to send the signals? It is the fat cells or the adipocytes, which is secreting leptin and adiponectin, the stomach releasing ghrelin, the intestine releasing the peptide YY called as PYY, the pancreas releasing insulin. So I'm not discussing now which will do what, but I will discuss each of them individually. What is the function of leptin? What is the function of adiponectin? What is the function of ghrelin? All these things I will discuss in detail. But right now you have to understand that there's an afferent system composed of the adipocyte, stomach, intestine, pancreas. They are releasing certain peptides and hormones. Okay. And they are acting as an adiposity signal. Now, depending on their nature, some of them might stimulate the catabolic circuit, or some of them might inhibit the anabolic circuit. Okay, so depending, some of them might stimulate the catabolic and some of them might stimulate the anabolic circuit. Now, depending on the nature of the signal that we will receive, if for example, the catabolic circuit has been stimulated, then what will the catabolic circuit do? Its basic function is energy consumption. It is going to stimulate the energy expenditure, whereas it is going to inhibit the food intake. So for example, from the afferent system, from all the stomach, intestine, pancreas, adipocytes together, they release certain signals that ultimately stimulated the catabolic circuit in the hypothalamus. Okay. So over there, either they are going to cause energy expenditure, they are going to cause usage of energy, and they are going to inhibit the food intake. Is this very clear what the catabolic circuit is going to do? They are going to break the body fat and they are going to cause energy utilization. They are going to cause loss of our fat. Whereas on the other hand, if the adiposity signal is such that they are going to stimulate the anabolic circuit, if they stimulate the anabolic circuit, then the anabolic circuit, what they are going to do? They are going to do the reverse. They are going to inhibit the energy expenditure. And on the other hand, they are going to stimulate the food intake. So normally in our body, both the anabolic and the catabolic circuit are working with each other so that they maintain proper energy balance. Neither there should be excessive food intake, neither there should be excessive expenditure. Both of them should be balanced with each other. This is what normally it should be. Okay, and this is basically regulated at the level of the central processing unit, that is the hypothalamus. Is this point very crystal clear to everyone? This basic concept is clear. Afferent system, efferent system. What is the role of the hypothalamus over here? What is the catabolic anabolic circuit? So this is the step number 1, that this should become very clear. Can I move ahead now, everyone?
Yes, sir.
Okay. Now with this concept in our mind, let us go one step ahead. We will understand little bit in more details how this thing is taking place. So you have to understand that there are two groups of neurons in the hypothalamus. One is the POMC CART system that we can appreciate over here. Another one is your MPY-AGRP group of system, the group of neurons. And these group of neurons, they are basically present in the arcuate nucleus of the hypothalamus. They are present in the arcuate nucleus of the hypothalamus. Now, very important, there is a basic pathway. Okay, that is, first we are having the first order neurons that is going to release something at the level of the synapse. Then there will be stimulation of the second order neurons, and finally there will be release of something at the synapse leading to something later on. I will just come to it step by step. Okay, so first we are going to understand the POMC CART pathway, or whenever there is a stimulation of these group of neurons, what is going to happen? When the POMC CART group of neurons, so this is the group of neurons, when they are stimulated, they are going to release melanocyte stimulating hormone alpha MSH, that is going to stimulate the second order neuron, that is melanocortin 3 or 4R receptors, that is going to release the thyroid releasing hormone or the corticotropin releasing hormone, which is going to stimulate energy expenditure. So we can say that the POMC CART group of neurons ultimately is going to be catabolic or anorexigenic in nature. Catabolic means that they are going to cause energy expenditure, and anorexigenic means the patient will not become hungry. Okay, the appetite will be suppressed. Is this very clear? This particular pathway, the POMC CART pathway, releasing the alpha melanocyte stimulating hormone, stimulating the second order neuron, that is melanocortin 3 or 4R receptor, releasing the thyroid releasing hormone or the corticotropin releasing hormone, which is going to stimulate the energy expenditure. So this pathway, we can call it as a catabolic or anorexigenic pathway. Is this crystal clear? Is this part clear? The POMC CART group of neuron pathway?
Yes, sir.
Okay, now we come to the second group. It will be completely opposite to the first group. If someone is stimulating the NPY-AGRP group of neurons, they are going to stimulate, they are going to release NPY at the synapse, that is going to act on your classical Y1 or 5 group of neurons, that is going to release your melanin concentrating hormone and orexin that is going to stimulate the food intake. So finally, this pathway is anabolic, which is going to build up the body, and they are going to stimulate the food intake, increase the appetite. So they are called as orexigenic. So you have to remember POMC CART, that means energy expenditure, that means catabolic, that means anorexigenic. And we have to remember the NPY-EGRP, that means we will have to take food, anabolic or exigenic. Is this very, very clear? Now, this part that we see over here, thousands of MCQs are asked at this part. So remember these 4 part full forms you don't need to know, even I don't know. Some of them that I knew I said, but you do not need to know. In the exams, questions are being asked at this, that what is released by the POMC CART neuron, okay, what is released at the synapse, or what is released in the NPY-AGRP pathway, or which receptors of the second order neurons are they stimulating. Is it very clear? This second step is clear, how regulation of energy balance is taking place via which group of neurons. One group is POMC CART, another group is NPY-AGRP. Now what we are going to do, now as I told you when we were discussing, I told you that this afferent system is composed of many different things, and depending upon which is released from which organ or which tissue, okay, we will have certain adiposity signals, which is some of them is either going to stimulate the catabolic circuit, some of them is going to stimulate the anabolic circuit. I told you this. So now let us understand how and what is going to be released, and which particular hormone is going to do what. The first very important group of hormone over here that we are going to read, the molecule that you are going to understand over here, is the group of leptins. So understand very thing. Again, MCQs will come. All of the following is true regarding leptins, except the term leptis is basically meaning thin. Okay, and it is basically synthesized from the OB gene, OB gene. Now, OB receptor, now the receptor that is there, the OB receptor that is there, it is a type 1 cytokine receptor superfamily. Now, the leptin is going to stimulate the POMC CART pathway, and it is going to inhibit the NPY-AGRP pathway. So, you tell me, what is the end result of leptin activity if excessive leptin is released? Tell me, what is going to happen? It is stimulating the
catabolism, sir.
Yes, there will be catabolism. Very good. There will be catabolism. So how our body is going to release the leptin? So when there is a food balance, when the fat stores are abundant in our body, we have a lot of fat. So what will our body do? Our body will start to release excess amount of leptin. Why? Because leptin is going to break down that fat. That is what is required. Similarly, when the fat stores in our body is inadequate, it is going to decrease the leptin secretion. Because over here, I need to create an anabolic state. Very clear, not very difficult. Okay. Coming to the cytogenetics, if there is a loss of function mutation in the OB gene, that can lead to an early onset severe obesity. Mutation in the melanocortin 4R receptor and the downstream pathway can lead to no sensing of satiety or decreased sensing of satiety, and again leading to severe obesity. Insufficiency of the brain-derived neurotropic factor, that is BDNF, which is a component of the melanocortin 4R receptor downstream pathway, is also associated with obesity in patients with Vagar syndrome. Okay, this Vagar syndrome you will read in case of Win's tumor. Now, what are the functions of the leptin? What does the leptin do? They stimulate physical activity, heat production, and energy expenditure because they are catabolic. They also stimulate thermogenesis to create heat. Leptin can also act as a pro-inflammatory cytokine and help in regulation of hematopoiesis and lymphopoiesis. OB receptor is structurally very similar to the interleukin 6 receptor, and they stimulate the JAK-STAT pathway. This is all about the leptin. Now we will come to the next molecule. Very important is the adiponectin. Adiponectin is called as the guardian angel against obesity. It is the fat burning molecule. So remember these names. Okay. So they are secreted from where? From the adipocytes, and they stimulate the fatty oxidation inside, fatty acid oxidation inside the muscles. Therefore, they cause decrease in the fat mass. So they decrease the influx of fatty acid to the liver by utilizing the fatty acid in the muscle. So they also decrease the hepatic triglyceride content. They decrease the glucose production in the liver and they increased insulin sensitivity. So in this way, they are providing protection against metabolic syndrome. Now they act on two receptors. One is adiporeceptor 1, R1 and R2. And these receptors are highly expressed in both the liver as well as the skeletal muscle. And it is also very understandable because the major action of these particular hormones, if you see, they are at the level of the liver and the skeletal muscle only. Okay. Is it all right, everyone? The next group of hormones is from the stomach. So the gut hormones, very, very, very important. So what are the hormones over here that we are going to read? Ghrelin, peptide YY, pancreatic polypeptide, insulin, amylin. So the first very important thing, that is the ghrelin. It is produced in the stomach and from the arcuate nucleus of the hypothalamus. So it is the only gut hormone which is orexigenic. What is orexigenic? That is going to stimulate eating. Right. That is orexigenic. Now, how is it orexigenic? Ghrelin is basically stimulating the NPY-AGRP group of neurons. So basically that that is going to stimulate food intake. We have already read about it. So the levels of ghrelin, they rise before meals and they fall between 1 to 2 hours after eating. Very, very important MCQ. Okay. Is this very clear to everyone? Can we move ahead? The second group over here is the PYY group. The second group over here is the PYY. It is released from the endocrine cells of the ileum and the colon. Okay, they are released from the endocrine cells of the ileum and the colon. Now, they are the one which is inhibiting, your NPY-AGRP group of neurons. So normally it is inhibiting. As I told you, ghrelin is the only one to stimulate this pathway. So basically remember that its level decreases in a syndrome called as Prader-Willi syndrome, which I will teach you in obesity. Okay, and over here basically Prader-Willi syndrome is a syndrome which is characterized by hyperphagia and obesity. It is characterized by hyperphagia and obesity. Okay, and also remember this PYY as well as amylin. Okay, they act centrally to stimulate the POMC CART pathway. Is this very clear to everyone? Okay. Now the next is the adipocytes. Now adipocytes, basically our fat cells are the sites of synthesis of leptin as well as the site of synthesis of adiponectin. And they also release, in addition to the release of these molecules, they are releasing certain pro-inflammatory molecules like interleukin 1, 6, 18, interleukin, TNF, chemokines. So all these things, they create a chronic pro-inflammatory state which is characterized by an excess levels of CRP. So this we already remember from our previous lecture. Okay. Is my voice audible to everyone? Okay. So this adipocytes, if you see, the total number of adipocytes, here a very important concept is again into play. The total number of adipocytes which is established in our childhood and adolescence remain constant. And in adulthood, the loss of fat mass, or when you become thin from being obese, that is only occurring by the shrinkage of the fat cells. This is a very important concept to understand. That means I'm not saying that when you are a child or when you are in adolescent period, you shouldn't have food. You should have, but you should have correct food. You shouldn't have a lot of junk food, because the kind of fat and the amount of fat cells, okay, that is increased in that time, that basically will remain constant throughout your life. So that is why it is very important from a very young age to have proper food, because later on in adults, for example, if you have developed 100 amount of adipocytes, so this 100 adipocytes that you have developed already, so you are not going to become thin by reducing the amount of your fat cells. You are going to become thin only by means of shrinkage of these fat cells. So the number of fat cells will remain the same, only you will become thin by reduction in the size of these fat cells. Now, dieting and exercise therefore should be sustained, else the body will go back to the pre-diet levels. So this is a very important concept to understand. That is why once you become thin, and again if you start overeating, you will go back to the same size and shape. Okay. Now, alteration of the gut microbiome also plays an important role in development of obesity. Okay. So what are the consequences of obesity? It is associated with increased insulin resistance as well as hyperinsulinemia, leading to predisposition to diabetes mellitus type 2. This hyperinsulin levels can cause excessive sodium retention and excessive release of norepinephrine, causing hypertension. It can also increase the blood volume and causes smooth muscle proliferation. It can lead to hypertriglyceridemia, will decrease in the HDL levels, which increases the risk of coronary artery disease. It can also lead to non-alcoholic fatty liver disease. It can lead to increased risk of cholelithiasis or decreased flow of the bile. So more stasis of bile will occur. So the risk of gallbladder stone becomes 6 times more, okay, with obese individuals. It causes one syndrome called as hypoventilation syndrome, called as Pickwickian syndrome, a favorite MCQ for the examiners. It is characterized by day and night hypersomnolence associated with a sleep apnea. So you stop breathing. There is a hypoxia when once you sleep, and every time you wake up. So your sleep becomes bad. And in the long term, it causes polycythemia and can lead to right-sided heart failure because of pulmonary hypertension, leading to cor pulmonale. It can lead to degenerative joint disease like osteoarthritis, and it also increases, obesity can increase the inflammatory markers as we have seen above, the CRP and the TNF, and all this can be increased, which can further cause the complications of obesity. Very important exam question: how is obesity predisposing to cancer? So it is associated with the cancers of the esophagus, pancreas, cancers of the colon, rectum, breast, gallbladder, and the kidneys. It affects 4% of cancers in the men is attributed to obesity and 7% of cancer in women. Why there is a difference? Why there is a difference between men and women? Very basic question. Amount of fat in female is more as compared to men. Okay. So how does obesity predispose to cancer? Now, it causes an elevated insulin level. Okay. How it causes? Because it is causing insulin resistance. It is causing insulin resistance that is leading to increased hyperinsulinemia, increased insulin levels in the blood. And that is inhibiting the production of a binding protein that is called as insulin-like growth factor binding protein 1 and 2. Now, hyperinsulinemia is inhibiting the production of these binding protein. So normally in our body, we are having a release of insulin-like growth factors, which is one type of growth factor. And this insulin-like growth factor has a receptor called as insulin-like growth factor receptor 1. So if the amount of binding protein is one protein that is going to bind and keep the insulin-like growth factor 1 and 2 in the bound form. So suppose there's a decrease in the binding protein of insulin-like growth factor, then what is going to happen? There will be an increased release of insulin-like growth factor 1, which is going to bind to the receptors, that is insulin-like growth factor receptor 1. And once they bind to this insulin-like growth factor receptor 1, they will activate all the pathways of growth and differentiation. That is the MAP kinase pathway, the RAS pathway, the PI3K-AKT pathway, leading ultimately to growth and proliferation. Is this very clear? That how obesity, by causing insulin resistance and ultimately hyperinsulinemia, causing growth and proliferation of the cells and thus predisposing to neoplasia. Okay. Now, obesity and hyperinsulinemia not only causes that, but it also increases the synthesis of estrogen from the androgen precursors by stimulating the enzyme, peripheral aromatase enzyme. It increases the androgen synthesis in the ovaries and in the adrenals. It enhances the estrogen availability in obese persons by inhibiting the production of sex hormone binding globulin. So all these factors leads to an excessive amount of estrogens and androgens. And what does excess amount of estrogen do? Did I not say that excess amount of estrogen causes estrogen hyperplasia, endometrial hyperplasia, endometrial adenocarcinoma can cause? Yes or no? Which type? Sir. Which type of endometrial carcinoma? Type 1. So that is also one neoplasia. So in this way also obesity is leading to neoplasia. Also obesity, in obese people, the amount of adiponectin decreases, which is the savior molecule. Normally adiponectin is associated with decreased cell proliferation and it stimulates apoptosis. So it controls the cell proliferation by stimulating P53 and P21, which are tumor suppressor genes. So normally they do that, but in obese people, the amount of adiponectin will come down. And also obesity has a pro-inflammatory state, which itself is carcinogenic in nature. So in the end, I am going to complete by just ending with this, that what is the basic point over here. The leptin, if you see, they stimulate the POMC cart, and accordingly there will be stimulation of the breakdown pathway. Now the PYY and the ghrelin, if you see, the PYY is going to directly inhibit your NPY-AGRP pathway, and the ghrelin, if you see, they stimulate this NPY-AGRP pathway. Now, do you think this is correct that I am showing you, or is it ulta? Yes, tell me. Is it all right, or is there any changes that you wish me to? Because I just want to check whether you people have understood or no. Or do you agree with whatever I said? Yes, tell me.
Yes, sir.
Yes, really it is yes. That means you all did not understand. This is completely opposite. Yes or no? What does the ghrelin do? Ghrelin is going to do what? It is going to stimulate the food intake. Whereas the PYY, amylin, all of them will inhibit the NPY-AGRP. Yes or no? Yes. What did we read over here? Yes, they are inhibiting. The term is inhibit. Whereas the only one which is orexigenic is this. Orexigenic means what? Ghrelin. So this is very, very confusing. That is why in the end I have given this on purpose. So go back and read and revise. Okay.
Okay.
So thank you everyone for watching this lecture. I hope you all have enjoyed obesity, and take care.